Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I want to talk about plantar nerve entrapments. It was interesting timing. I was at the office yesterday with Dan Dominguez. We were doing some photos for his slide presentation that we're doing for his part of the 3-day seminar that we're teaching in Sydney, Australia at the end of July. He's doing all sorts of cool nerve trunk stimulation, and one of those nerve trunks that he was stimulating was the plantar nerve trunk. He showed me that previously, and I've been using that with very good success for a lot of foot pain and foot numbness patients. And so that was the topic I had in mind already for today, because I'm working on a patient who's over 60, and she had a lot of foot numbness after a really bad bout of sciatica that was resolved by acupuncture, but she had this residual numbness on the bottom of her foot, especially the lateral part of her foot. It was so bad before she was seeing me that she couldn't drive, and then she was only able to drive with her shoe off because otherwise she couldn't feel the pedals. And now she's feeling more. I think we're to like 50% improvement. Or 50% sensation, and her physical therapists are very excited about seeing her progress because they didn't really expect it. And so she told me that they're all over our website looking at me and Dan with interest. And the important thing you think about for seniors especially, they're so much more prone to falling because they've lost proprioception in their hips and ankles. And if you can't feel the floor, you're way more likely to fall. She walks with she has a cane, and she has a sort of like a push stroller type thing when she feels unsafe. When she basically says, if I'm going somewhere where I'm unsure of what I'm going to encounter, I want my my 2-hand stroller. Otherwise, I could just use a cane, or she can hold her husband's arm. But anyway, that's a long way to tell you that I'm having good success with her by treating the plantar nerve trunk as well as a couple other muscles that I'm going to talk about, like the Abductor Hallucis and tibialis posterior. So I don't know if you're familiar with orthopedic acupuncture. I just want to put out there that you really should consider getting a very good medical reference for nerve entrapments, peripheral nerve entrapments. I have a book that I love because it has great photos. They draw lines and triangles and squares to show where the injection would be for these nerve entrapment patients. And there are good explanations of what muscles are doing the entrapment of the nerves. So I found this to be a really good reference just for almost anything that you're working on. If you suspect there's a nerve entrapment, this is a great resource. I'm going to put a link in the copy for this podcast for the book that I use, but obviously there must be many very good manuals out there for people who treat nerve entrapments. It's really made for medical doctors who were using an injectate. But what's interesting is that the woman who wrote this book, she likes to use some electric stimulation on her needle, on her injection needle. And I find that very interesting. It must be that she has found that it gets a better result because it's actually releasing the muscles that she's injecting into. So good argument for not even needing the injectate, if you ask me. So peripheral nerve entrapments of the foot. You know how the Tom, Dick, and Nervous Harry is the way to remember the muscles of the low leg that are not the gastrocs and soleus. You've got Tom is tibialis posterior, Dick is flexor digitorum longus, Nervous is the tibial nerve, and then Harry is the flexor hallucis longus. That's the order from when you're looking from this from the medial part of the leg, from behind the tibia. You've got Tom, Dick, and Nervous Harry. So that is a great way to remember how those muscles line up when you have to go into that area behind the tibia. It's going to help you avoid hitting the tibial nerve. And as those muscles in that nerve come down behind the medial malleolus, there's a retinaculum there. And so they're going underneath that retinaculum, and the tibial nerve divides around that area and becomes different branches that are then labeled plantar nerves. But they're just different branches from the tibial nerve. So as they split, you get a calcaneal plantar nerve, you get a medial calcaneal nerve, and you get a lateral nerve. So that you've got the plantar, you've got the lateral plantar nerve, the medial plantar nerve, and the calcaneal plantar nerve distribution. So calcaneal, as you might guess, is under the heel. The medial is most of the instep and the ball of the foot and the first toes. And then you've got the fifth toe, the little pinky toe, and the outer part of the bottom of the foot, which is the lateral plantar nerve. That lateral one is the one that's the most numb for this patient that I've been working with. But it was the whole foot. But after one or two treatments, her sensation in the medial plantar distribution have completely been restored. The lateral one's been a little tougher. So I just wanted to talk about the common entrapments. If you're interested, look up Tarsal Tunnel syndrome. That's often what this will get called for those entrapments. But it's good to know the different ways that those different plantar nerve branches can get entrapped, because they're not all identical. A generic tarsal tunnel syndrome, I would typically treat by treating the tibialis posterior, because that's most likely what's going to be tight and pressing, especially if there's some sort of tendinitis that's going to be pressing on the tibial nerve where it splits to become the plantar nerve branches. And then abductor hallucis. And abductor hallucis is so important for these plantar nerve entrapments. It's involved or possibly involved for any of the three. So really check abductor hallucis. And you can often put a couple needles, like one just below the navicular, and then you can go back toward the heel and put a needle there. what I find interesting is that before I really started looking further into nerve entrapments from these medical books, I would assume that medial heel pain was coming from abductor hallucis, and my assumption was that it was just a pain referral from that tendinous attachment at the calcaneus. But having started to really delve into more of the nerve entrapments, I believe there are very likely people that got relief from the treatment, not for the reason that I thought. I thought by releasing the muscle, that's why their pain went away. It's possible by releasing the muscle that it took pressure off of entrapped nerves. So both got the good result, but I'm just saying I might need to revisit my thinking on why it helped. It might not have just been a muscular attachment sort of pain referral. So when you do have those medial heel pain patients, consider that it could be calcaneal branch of the plantar nerves. So I'm just going to quickly tell you the main entrapment muscles for each of those distributions. The tarsal tunnel, that's that probably first visit. This is really what you should be considering is tibialis posterior and the abductor hallucis number 1 and 2. I do like to add the nerve trunk with some stimulation from a pointer Excel. That's something you really need to learn in a class because you got to be able to palpate it and needle it and stimulate it properly. And really only way to learn that's to actually see it done. It's not one that you're going to wing on the fly with a patient unless, if you decide to, make sure that your face is not over their foot because they might kick you. But that nerve trunk stimulation can really help to regulate a nerve that's either not that causing numbness or pain or both. And then the little adductor digiti minimi, the little muscle that abducts out the little pinky toe. That's another good one to stimulate. It can be part of that neuropathy, the numbness or pain. That especially sciatica. You see this with sciatica sometimes. People have pain or numbness on the outer part of their foot post sciatic flare up. So you'll clear their sciatica, and the only thing left that's bugging them is that outer part of the foot. So that could be nerve entrapment of the lateral plantar nerve branch, which is primarily going to be entrapped by the abductor hallucis because that nerve actually passes through the muscle, through the abductor hallucis muscle. So that's a really prime one for entrapping that lateral plantar nerve. And then I would also treat that abductor digiti minimi muscle as well with some electric stim. So tarsal tunnel, like I said, tib posterior abductor hallucis, and possibly that digiti minimi. And then for the medial distribution, that is very likely from the abductor hallucis, though I would still consider treating tibialis posterior, okay, because it could be entrapped. And what's interesting is there are a lot of variation on where the nerves split. So they look at cadavers and they try to figure out where the tibial nerve breaks off into different plantar nerve distributions, and they vary so much on different people. So you can't always know for sure. So I would always just consider treating tib posterior abductor hallucis for any of the three. And then as it gets better, really hone in on probably abductor hallucis. The calcaneal distribution, that when it's just the medial calcaneal, it's usually abductor hallucis, but when it's total bottom of the heel pain or numbness, look at abductor hallucis and quadratus plantae, the one you never want to have treated on yourself, because it's going to be a big long needle in the bottom of the foot right in front of the heel. But if it has to be treated, it has to be treated, right? So, it hopefully doesn't take too many treatments. But that quadratus plantae can also entrap the calcaneal nerves. And it's just interesting because when you think of plantar fasciitis, how many times has somebody been given that diagnosis that it was possibly a plantar nerve issue more than a plantar fascia issue? Because those different pain patterns could be from the nerve entrapment. Or what if it's both? So really, it's good to just kind of know that those are possibilities for people. And when you have someone come in with numbness, especially if it's only on one side, look for nerve entrapments, because if it's bilateral, I'm gonna think it's more like spinal compression type issue. But if it's one-sided, think about nerve entrapments of the plantar nerve branches from the tibial nerve, because it's been really, really helpful for me to look at it that way and treat accordingly. And that plantar nerve trunk added in is a really, really helpful one to consider. And then I guess the overarching theme of today's episode is look for a reference that you like, that is about peripheral nerve entrapment. And I'll put the link to the one I have, but you might already have something, or you might find something that you like that's in a different language that's not in English. Whatever you can find that you like is bound to be really helpful for you as an orthopedic acupuncturist to start understanding nerve entrapment as an issue for headache, all sorts of arm and hand numbness, foot numbness, like lateral cutaneous nerve entrapment, things like that. Just really good to see in a manual for doctors how those nerves get entrapped. It's going to give you a whole lot better insight into how to treat those issues. And once you've been reading those books, you just spot it instantly when someone comes in, and you already know where to look, and you're not taking a lot of time out to go look it up, because you've been reading those chapters and you've treated some patients and had success. And then, like I say, when you see it, you pretty much know where you want to palpate to see if there's any sort of sensitivity, muscular tension, etc., that leads you to believe that that's what's going on. So that is the episode for today. And I will talk to you soon. Have a great July 4th weekend.